Good afternoon, everyone, and thank you so much for joining us. So I'm Hima Vaidula. I'm co-governor of the New York chapter of the American College of Cardiology, and I'm here today with my co-governor, Dr. Hari Naidu, and we're proud to present the next installment in our Aftershock series. And these Aftershock sessions provide bite-sized recaps of high-impact lectures from prominent cardiology conferences, such as ACC, HRS, HFSA, AHA, SCAI, and more. So with that, I'm going to hand it over to Dr. Hari Naidu, my co-governor, who is going to introduce our esteemed speaker tonight.
Thank you, Dr. Vaidula. My name is Hari Naidu. I'm the Downstate Governor at Westchester Medical Center. We have a treat today. I think this is perfect timing. At ACC 2022, there was a presentation as the first late-breaking clinical trial. I was there in the audience of the Valor trial. I had the honor to work with our guest speaker, Milind Desai, on the executive committee and as a PI in our local hospital here for the Valor trial. So I have some intimate knowledge of it. And this is perfect timing also because the publication just came out. So this is our opportunity to really dive into it a little bit more, what this means for cardiology and hypertrophic cardiomyopathy. So I do want to introduce Dr. Desai, who's a longtime friend of mine. He's at the Cleveland Clinic. He runs the Hypertrophic Cardiomyopathy Center and has worn a lot of different hats there, including Chief of Clinical Operations in the cardiology section. So without further ado, he's going to take us through this trial that just came out in April and is now just published in Journal of American College of Cardiology on July 4th. Milind?
Thank you, Dr. Naidu, Dr. Vaidula, and everybody that is joining. It is indeed my privilege to discuss the results of the Valor-HCM trial. Here are my conflicts of interest. Hopefully everybody can see my slides well, correct? Yes. So, Valor trial was looking at myosin inhibition to defer septal reduction therapy in advanced symptomatic obstructive HCM patients. As all of us know, HCM, hypertrophic cardiomyopathy, with a prevalence of about 1 in 200 to 500, it is a primary LVH myocardial disorder where there's no secondary reason for that degree of hypertrophy. And 2/3 of these patients, if looked for carefully, have obstructive hypertrophic cardiomyopathy, which is characterized by dynamic obstruction to the flow of blood in the outflow tract, left ventricular outflow tract. The current state of affairs as it relates to medical therapies have not been developed specifically for HCM. And in patients with advanced symptoms, typically we recommend septal reduction therapy, especially when they have intractable symptoms despite maximal medical therapy. And to be doing SRT and get optimal results, you require specialized care that is not widely available. So there is an unmet need for non-invasive alternatives to SRT. Mavacamten, it's a targeted inhibitor of cardiac myosin, which reduces the significant excessive contractility, which is characteristic of HCM, by reducing myosin-actin cross-bridging. In prior data, it has been shown to improve LV outflow tract gradient, quality of life, and physical functioning. So having said that, Valor study, HCM study, was designed as a randomized multi-center in 19 US experienced HCM centers where 56 patients were randomized to mavacamten ranging from 2.5 to 10 milligram dose and the equal number to placebo after a screening period of 2 weeks. Everybody underwent extensive evaluation at baseline and then had monthly echoes. The important thing here compared to the other previous data is we use real-life echocardiography assessment to guide up or down titration. And this was done through core lab measurements. Bottom line is what Valor-HCM sought to determine is if addition of mavacamten to maximally tolerated medical therapy would allow such symptomatic, severely symptomatic obstructive HCM patients to improve sufficiently to a point where they no longer met guideline criteria for septal reduction therapy or chose not to undergo septal reduction therapy at 16 weeks. So remember, 100% of patients met criteria for SRT at baseline, and we wanted to see how many of them fell off of that eligibility requirement. So What are the baseline and the primary data? This was a nice, well-distributed, representative HCM population, almost 50% female gender, 93% were class 3 or higher, and everybody was on maximally tolerated medical therapy. The difference compared to the previous data is a lot higher proportion of NYACC class 3, and combination therapy was allowed, including 1 in 5 patients who also got disopyramide, which is typically considered third-line therapy. Everybody had significant elevation of resting or post-exercise LVOT gradient as shown in the slides. What we were able to show, the primary endpoint in the mavacamten group, out of 56 patients at 16 weeks, only 10 remained eligible or chose to proceed with SRT at week 16. So even in a short time frame of 16 weeks, 82% patients no longer met criteria for SRT versus placebo, 77% still remained eligible. This difference was highly statistically significant. And importantly, 95% patients chose to continue in the long-term extension arm at week 16. Looking at some of the secondary efficacy endpoint, so the gradients in the mavacamten group, the resting as well as Valsalva LVOT gradients significantly improved at week 16. KCCQ score significantly improved, and so did BNP as well as troponin I. Importantly, 63% patients in the mavacamten group had at least 1 class improvement, and 27% had at least 2 NYHA class improvement at week 16, compared to 77% in the placebo group who did not show any significant improvement. This was well tolerated. There were no permanent treatment discontinuations due to significant drop in EF less than 30%. There were 2 patients who had a short-term reduction, stoppage of the drug due to a mild reduction in LV ejection fraction, and the side effect profile was very well tolerable. Ejection fraction, as shown in the Kaplan-Meier curves, was no significant different in placebo versus mavacamten. There were no serious adverse events of syncope, CHF, or sudden cardiac death. So with that, I will end, and we will have a discussion about the trial. But the bottom line is 82% patients after week 16 of being on mavacamten, which was done using real-life titration of echocardiography, they no longer met criteria for SRT. And these were highly symptomatic advanced disease patients on maximally tolerated therapy. Thank you so much.
Thank you, Milind. I think it's fantastic. I think, this was very long awaited. As you know, we had the Explorer trial, and the main criticism of the Explorer trial, although it definitely met its endpoint and was good proof that this was helping on an anatomic and physiologic basis, was that it was mostly class 2 patients. So now we have more sick patients, and the benefit was still very strong. So the first question I have is a little bit about the data itself. So you said that 80% of patients were no longer eligible. Do we have an idea of what % of that is because of no longer having the gradient versus the patients who are no longer sufficiently symptomatic? Or was it mostly driven by gradient reduction or mostly driven by symptom improvement?
So this is interesting. So we, in real life, we don't practice medicine based on numbers. So every patient, and we recruited a fair bit. So every patient, we had to make an independent judgment of their symptomatology. That was totally blinded and independent from their echo data. So in order to maintain eligibility, or in order to drop off of eligibility, you had to have at least 1 class symptom improvement and significant improvement in your maximal outflow tract gradient. So it was not one or the other, it was both in order to meet the rigid criteria. And we kept the criteria rigid for a reason. We did not want any wishy-washy results. So bottom line is, both of those had to be trending in the right direction. And as it turns out, as you saw in the data, not only did the symptoms and the gradients trend in the right direction, but all the biomarkers, all the secondary efficacy endpoints also trended in the right direction, each one of them. That's
great. So as you know, we both take care of a lot of patients with hypertrophic cardiomyopathy, and there was an editorial that accompanied this. And I think, every hospital and center is doing things a little differently in HCM. Some places move quicker to septal reduction therapy. Some places continue to titrate multiple medications, including disopyramide. I think I'm one of those that does a lot of disopyramide, multiple medications, but I also move to SRT in appropriate patients who I think are not going to benefit sufficiently just based on experience. What is the sweet spot for this medication? That's the question. Where do you think that it's going to, do you think that we should be using it more to eliminate SRT, or do you think that patients are still going to want SRT at an early junction? And that was part of the editorial that kind of implied by Dr. Amin that many patients, that sweet spot may not be as large as we think. I'm not so sure about that.
So thank you very much for diving straight into the editorial. So that's good. Having said that, Mayo Clinic participated. Dr. Amin did not, but his colleagues participated in the trial, just so that everybody's aware. So they recruited, and I'm very thankful for that. Now, the way I look at it, first of all, this is first in class, and we are going to evolve our understanding of the drug and our ability to take care of these patients with the new kid on the block. This is how I look at it as follows. Number one, so currently it is approved for class 2 or 3 patients. Valor data suggests class 3 patients that are more sicker as an alternative. So how do I look at it? Number one, is there a group of patients in whom we will be able to avoid SRT altogether because they feel so much better? Number two, is there a group of people who may feel that they may want to delay an SRT for whatever reason? My kid's getting married. I want to go here, there, whatever. I don't want to have surgery for 2 or 3 more years. There's a group that may be high risk for an SRT or may not have a good anatomic substrate for alcohol ablation. And there's a huge group that people don't realize, which is lack of access. Now, why is it important? The important thing is as follows, and some of the data that has been published out of NIS, including some of the stuff you've shown. If you go to an experience center, your surgical or SRT outcomes are mortality. 30-day mortality is less than 0.5%. If you go to a less experienced center, that mortality could reach up to 16%, 1 in 6 patients. So, with due respect to the editorial, if you are living somewhere in the middle of nowhere with no access to a high quality SRT, the likelihood of you having potential access to medical therapy is much higher. So it is not a one size fits all. There's different strokes for different folks. Honestly, and look, it is not about naysayers. The editorial does do the right thing by saying, this is not a panacea for everybody, but but we also have to recognize that evolution, every step of evolution, every step of progress in mankind has been met with certain naysayingness, if that is ever a word. But we have to continue to strive towards generating high quality data. At the end of the day, look, what gets you a real class 1 level of evidence in a guideline is a well-done, multi-center, randomized controlled prospective trial, not a retrospective observational trial. So, we have to strive towards getting class A level 1 type evidence.
I do think your access issue is important because, I've traveled the country teaching alcohol ablation, starting centers, and the truth is, it's throwing pebbles, right? It's very hard to move the needle if you're doing things one place at a time and trying to optimize outcomes. There's whole parts of the world that can't have those outcomes or don't have access, whereas medications can eventually access different parts. If the cost comes down, they become generic and whatnot. So I think we're on the right track.
Look, the way I use the TAVR analogy, okay? TAVR did not eliminate surgical AVR. It just made up the game. Now we know which patients are better for TAVR, which patients are better for SAVR. It's as simple as that. And if we just say we are not going to develop a new technology or a new technique or a new molecule because it challenges our way of thinking, traditional way of thinking, then we'd still be riding horse carts.
So where do we go from here? I know I'm going to be doing a trial in the non-obstructive HCM. And there's also other medications, mavacamten, that we're doing a randomized trial. And there's also, outside of the HCM field, HFpEF. So Dr. Vidula, what do you think about that in the HFpEF region? Is that something that heart failure doctors are eager to think about with these novel medications?
That's a good question. And thank you, Dr. Desai, for an excellent talk. I think one of the issues with, as we're all aware of with heart failure with preserved EF, is that there's so many different phenotypes of heart failure with preserved EF. And I don't know if Dr. Desai, you're able to comment on any of the ongoing studies and pilot studies of this medication in that population.
So there's obviously studies being planned. They are in planning stage, and hopefully you'll realize I cannot talk much about what is being planned, but you are absolutely right. I mean, look, there is a group of, I would say, a huge unmet need. Right now, you know what? Let's simplify things. If I have somebody with a high gradient and outflow tract obstruction, and if I have access to a high quality surgeon with 0% mortality, yeah, that's a great place to go. But put another type of patient. I have another patient with a 2.5 centimeter wall, but no obstruction. The guy is still in class 3-4 heart failure, and I cannot elicit obstruction. I don't have much to offer to that guy. Yes, I can potentially offer him a deep myectomy, but the results are spotty. Having said that, so before transplant, we need to develop a new class of therapeutic options. That's the non-obstructive HCM piece. The HFpEF, I mean, you are more qualified to talk about HFpEF than I am, but HFpEF is a mixed bag. I think hypertensive heart disease, some undiagnosed or underdiagnosed non-obstructive HCM, some amyloid, and some others. I mean, obviously, this ain't gonna, we have better therapeutic targets for amyloid, so we are not gonna go there. But there's a whole different group of population where this, if it works, if it improves the quality of life, if it alters the basic myocardial structure towards better, if it improves symptoms, etc., then I think that's where the field should be going, and that's where
I would love to see a randomized trial, maybe low dose mavacamten or aficamten in those patients randomized. Obviously, you need good data, but it could be that low dose makes a big difference in that population.
Absolutely, and so this is now. So I'm glad Hari mentioned it, but so that's one class of drug. Then obviously there's going to be next in line molecules that are being developed. Then the next therapy, look, we have entered the brave new world of prospective randomized controlled trials. So I'm sure we are going to be talking in this forum a few years from now about gene therapy and slicing and CRISPR editing, all kinds of stuff. So sky's the limit. I mean, we can keep looking back and stay in the past, or we can keep looking forward as to how we can improve the life. Why wait till somebody gets to NYACC class 3-4? Can we work on them upstream, far upstream? These are all the questions that will be answered.
Well, thank you very much. I think that was fantastic. It was a good overview of the trial and some nice, healthy discussion about future directions and current utilization. So I want to thank you, Dr. Desai, for coming. I want to thank NYACC, Dr. Vidula, my co-governor. This will be on YouTube within a couple of days, and we'll push that around and hopefully get a lot of people interested in this topic as we roll out this medication. Thank you
so much for having me the forum for this. Thank you so much. Perfect.
Thank you.